Before we get into all things lifestyle and medications, what people can do to lower their blood pressure, can you tell us a little bit about how much someone can lower their risk of having a heart attack, a stroke, or kidney failure by lowering their blood pressure?
Yeah, and I can tell you based on some reasonably good evidence that when you measure blood pressure, we use units called millimeters of mercury. So when you go and they say, oh, your blood pressure is 120 over 80, that's 120 millimeters of mercury over 80 millimeters of mercury. Much of our understanding of blood pressure is based on what happens to the upper number, the systolic, especially as you pass your 50th birthday age into the Medicare type age and Social Security type age. But the rule of thumb is that for every 1 millimeter that you reduce that upper number, you reduce your risks of cardiovascular badness by 2%. So if you take you make a change and it reduces your upper number by 5 millimeters. So you go from 120 or let's say 150 to 145. You've now reduced your likelihood of a heart attack, stroke, heart failure, cardiovascular death, and bad things by 10%. So the 5 times 2, it's a 2 for 1 kind of exchange. So that's the rough percentage change. And that's over the next 10 years. So it's most of our risks now are assessed over a 10-year time period. So if you had an 8% chance, you have a lesser chance if you reduce your systolic blood pressure, and your diastolic usually falls in line, the lower number as well.
And we spoke about kind of what is the optimal systolic blood pressure, but if we're thinking about that kind of 2% risk reduction for every 1 millimeter of mercury reduction in systolic blood pressure, how far down does that go? Is that down to that 115 millimeters of mercury mark and thereafter it kind of tapers off, or we just don't have the data there?
So the 1 millimeter, 2% rule of thumb is a back of the envelope rough idea of what you can expect. When we look at how blood pressure is related to risk, would that it were a straight line. It'd be really easy if that were the case, but of course it's not. It's actually kind of parabolic with the side facing upwards, so that every time you increase your upper number by 20 points, so going, for example, from 140 to 160, you doubled your risk by that. From 160 to 180, you've doubled it again. So you start at 120 to 140, that's twofold. 140 to 160, that's fourfold. 160 to 180, that's eightfold. So the risk is proportionate, but it's proportionate in what's called a geometric fashion instead of a straight linear fashion. So the moral of the story is that if you're looking at a blood pressure of 170 or 180, you get a lot of benefit just getting it down 20 points, much more than if you're 140 getting it down to 120 for the same 20 points. So the higher it is, the worse your risk categories are, and the more important it is to lower it, no matter how you choose to lower it, but getting it down is really helpful. But the risks are proportionately less as you get close to that magic number of 120 that the American Heart and the American College of Cardiology and everybody else with an A in their name tells us is currently the cutoff for what's considered good in terms of an upper number for your blood pressure.
And does that include kidney disease, kidney failure? Is the risk the same there?
Okay, so that's one of the skeletons in the closet here. I am a kidney doctor. And one of the things I would love to tell you is that, oh, sure, it's just as true for the kidney as for the heart and the brain and the circulation and your legs and other things. But sadly enough, we are hard-pressed with our existing knowledge base to say that the same benefits on stroke risk, on heart failure, on heart attack, and on cardiovascular-related death are equally true at all levels of blood pressure reduction for the kidney. And the reason why is not perfectly clear, but we see very little additional benefit when you lower the blood pressure below 140 for the upper number to preserve kidney function over time. And we measure that by a blood test called the creatinine. And creatinine is a waste product. Kidney's the only way to get rid of it. So if your kidneys reduce their function, the creatinine levels rise in the blood. And that's what we use to gauge the effectiveness of treating blood pressure in a trial where we enroll people who already have some measure of kidney damage. And their creatinines are a bit high. And when we look at the change over time, it's really hard to say that 120 is better than 140 or 130 is better than 140, but 140 is better than 160 or 180. So our level of good is at 140, not the current 120 to 130 that the American Heart Association and the other do-gooder groups for blood pressure say we should aim for. That said, one last thing. The kidney disease improving global outcomes, so we call it KDIGO for short, that's a group that meets periodically to say, what should the blood pressure goal be in a patient with chronic kidney disease? They still stick to the 120 that the American Heart and other people say is a really good blood pressure, not because it preserves kidney function, but because everybody who has kidneys also has a brain and a heart. So for the sake of the other target organs, they are claiming that we should still aim for values less than 120 using any measure we have at our disposal to get there.
Following our last episode, so part one of this conversation where we mostly focused on what high blood pressure is and what are the risk factors for that, I had a lot of people in the community say, I wish people would speak a little bit more about diastolic blood pressure. And I do think it's very commonplace, and I'm sure you'd agree that most of the attention is on systolic, that top number. So my question to you would be, is systolic blood pressure more important than diastolic? Or is there another reason why we kind of focus mostly on systolic? And what does it mean if someone has a normal systolic blood pressure, but their diastolic blood pressure is unusually high?
That's a great question and a good follow through. So let's back up a second and ask, what does the upper number tell us? What does the lower number tell us? We kind of look at blood pressure, especially blood pressure elevation, what makes the blood pressure higher, as resulting from two things. One is the squeeze, the resistance that the body puts up to flow. And it has to do that because if you need blood going to your brain and your heart all the time, you're not going to want to perfuse your skeletal muscle or your liver or whatever maximally. So the way in which the blood circulation controls the flow to each of the organs is through resistance. And so when you don't need blood, resistance is higher. When you do need blood, resistance falls. And so if you start to run, okay, your muscles will get more blood. But if you're not running, they get less blood, and it's controlled by resistance. And the diastolic blood pressure is our marker of resistance. The systolic, the upper number, that's due to a different factor. And the factor that more relates to the upper number is how stiff the vessels are, particularly the big ones like the aorta, the femoral arteries that go to your legs, the brachial arteries that go to your arms, and that sort of thing. When stiffness in your vessels increases, it gets harder to distend them. That's the upper number. So every time the heart beats and pushes out blood, it pushes out blood against a higher load. And so the systolic rises. And every time your heart beats and shoots some blood into your major arteries, you have two basic protein components in your blood vessel wall. One's called elastin, guess what that does, and one's called collagen or gristle. If you've ever had a steak with that little, light colored thing down the center, which you can't chew, that is collagen or gristle. So elastin's your friend. Every time the thing expands to hold the blood, the elastin helps bring it back down again. But if you think about it, every time you do that, you're dealing with a protein, a tissue. It's not indestructible. Over time, the protein fibers of the elastin crack or even break into little pieces. And so you lose elastin and you think, okay, so I'll just make more. Well, guess what? You don't make more after you pass puberty. So elastin is a protein that is really hardy compared to any other protein in the body. It has like a 40-year half-life. So you got tons of it. But if you have a little more stretch, or more frequent stretches, so a little bit more, change in size or number of heartbeats per minute, you're going to lose your elastin a little more quickly. And when you lose elastin, what the body replaces it with is the other one, collagen. So as you age, especially after the age of 50 or so, you see that the diastolic stops rising with age, because prior to 50, the two track together. But after 50, the diastolic falls and the systolic continues to rise, because the types of blood pressure patterns we see in the young are more driven by vascular resistance, because they haven't accumulated enough elastin damage to get to the point where they're stiff. But then as they pass 50, now stiffness takes over. So where do most cardiovascular events occur? They ain't in the 40-year-olds. Otherwise, we wouldn't insure them, right? They had high blood pressure. They tend to happen in older people. And that's why we aim at the systolic pressure so much, because as you age, it becomes the 800-pound elephant in the room when we're dealing with blood pressure. Plus, one of the things I've often taught my students and fellows and residents in the past is the diastolic blood pressure, the lower number, that tends to melt on medication. You can usually control the diastolic with anything you do, lifestyle measures, drugs, whatever it is. Systolic, much more difficult beast, harder to get control of, because now you're dealing with that gristle protein in the vessel wall. And the collagen is hard to reason with. And so it's a bit more challenging to lower the systolic. So to your question, suppose my blood pressure is 120/95. Is that bad for me? And the answer is, it depends a bit on your age. If you're younger, yeah, you probably are dealing with a higher resistance if there's no other good reason for it to be 120/95. And currently, we treat that, even though there's not much evidence on how much benefit you get by treating an isolated elevation in the diastolic blood pressure. But the argument is, okay, their vascular resistance is higher and we're planning on the future. So we're doing this for the sake of their brain and cognitive function in the future. We're doing it for the sake of their heart, so they don't have heart failure, the dreaded complication of high blood pressure in the Medicare crowd. Because heart failure is the most common thing that people are admitted to the hospital for when they're on Medicare. So it's expensive, it's repeated, and it's clearly linked to blood pressure control. Maybe not so much when you're young, but certainly some, but especially when you get older. So we do treat it, and what outcomes? Well, we're kind of banking on the future. So we're holding the carrot on the stick out here, saying we think it's a good idea, and it's usually possible to manage it with modest amounts of either lifestyle change and or medication.
Is a challenge there when treating an isolated, elevated diastolic blood pressure that whatever interventions you're choosing are also going to lower systolic blood pressure and not lowering that too much?
One of the fascinating things is that there's a principle in medicine called Wilder's, or because it's German, Wilders, Wilders. Wilder's rule or Wilder's law. And what it says is that the higher a biologic variable is, whether that's your blood sugar, your diastolic blood pressure, your systolic blood pressure, your cholesterol, whatever it is, the higher it is, the greater it falls when you intervene. So if you have a systolic of 120, honestly, that's not so high. But if you have a diastolic of 95, that is high. So when you treat that, you're going to get a disproportionate effect in general on the diastolic compared to the systolic pressure. And the same happens when you're dealing with a blood pressure of 170/70. You're going to get much more collapse in the 170, much less in the 70 when you're looking at, for example, an 80-year-old who's got stiff circulation and has that 170/70 type blood pressure. So you'll get some change in the systolic, but proportionately, in general, you'll see a little bit more benefit on the diastolic. It is so easy to do a bad job at measuring blood pressure. If you measure it too quickly, if your feet aren't supported, if your arm's at the wrong place, if your bladder's full, if you just had a cigarette or a cup of coffee, there's a dozen different things that can screw up a measurement. And almost all the time, Simon, when the errors occur, they raise rather than lower the result. So most times you get a falsely elevated blood pressure type reading.
Howdy, friends. I would love your help. You know this, we know this. There are ads on our podcast here at The Proof. That is what allows us to bring all of these episodes to you at zero cost. We're always looking for new ways to make this experience better for you. But to do that, we need to know a little bit more information about you and the things that you like and perhaps don't like. To help with that, we've created a survey. This survey will help us understand the type of guests and topics that you enjoy most. It's quick, easy, and a really meaningful way to support the show. So if you would like to help shape the show and the brands that we partner with, please head to voicingchange.media/the proof to fill out our audience survey. That's voicingchange.media/the proof. A few months ago, the new AHA-ACA guideline, one of those guidelines with the A at the beginning that you mentioned, on prevention, detection, and management of high blood pressure in adults was published. And in fact, I think we postponed the recording of this episode to wait for that to come out. Compared to the 2017 guidelines from the same groups, what would you say are the major headline changes or updates?
So there's a couple of things that are, I won't say new, but more emphasized, better emphasized in the current guidelines. For people that are into thinking, they are now focusing on cognitive function. And if you wait till someone starts down the Alzheimer or the vascular dementia pathway, you're too late. We know that there's a risk of cognitive decline in your later years when you look at the middle age and even younger ages. So you're investing in cognitive function in the future by treating blood pressure now. And so that's another goad or incentive to manage blood pressure when people are in their 40s and 50s, rather than waiting until they're in their 60s and 70s to do that. Second thing that's kind of new, there is an emphasis on risk again. Guidelines go back and forth about the role of risk, overall risk in managing blood pressure, a single risk factor. But now they're using a thing called the PREVENT guideline. This is kind of new. This is the first hypertension guideline in the US to recommend that. So if you go to a website called MDCALC, mdcalc.com, and you put in PREVENT, you'll see the PREVENT calculator. And we are enlarging our scope, if you will, on things that we put into the calculator to look at risk. And you can put in everything. There's multiple models that you can choose from. And then you can play with the blood pressure numbers to see what the benefits are. But that's in the current guidelines because they recommend using the PREVENT calculator to decide how aggressively to aim for a blood pressure less than 120. I've been debating this issue with some of the deities that exist in the hypertension guideline world. I am not currently one of those deities. I've been dethroned as of 2014 when the JNC8 guideline came out. But sometimes, Simon, it is really hard to get a systolic down below 120 without causing a lot of symptoms and a lot of extra lab testing and a lot of extra, honestly, coaching, sidelines, cheerleader, please take this medicine. It will benefit you in the long run. I promise you. But the issue about where the systolic goal should be, everybody kind of agrees less than 130 is a good goal. But some people have stated in print in the guideline that you should really aim for less than 120 when your PREVENT risk calculator says that you're at more than 7.5% likelihood over the next 10 years. So that's another aspect that's kind of new. The other thing is that when we treat high blood pressure, a lot of it's treated by, a guy or gal who's in a private practice often, who's got a very busy schedule trying to see 4 or 5 patients an hour. And meanwhile, what we have to do, at least according to guidelines, to really get a good handle on blood pressure is to make sure patients understand the role of how to measure it properly if they do it at home, the role of their diet in that. Especially, you mentioned salt a little while ago when we were talking. Salt's an important component. It's not the only one, however. And medication, and how often, what do you do if you miss a dose or miss a couple days dose? You went to Europe for a week and you forgot to take your pills with you and no one would write a script for you in Copenhagen or whatever. What do you do in that circumstance? And it turns out you have to document everything you do to get paid. And so we're asking a lot of our primary care folks in order to do a good job of measuring blood pressure, teaching patients about blood pressure, prescribing the correct things, etc. So the guidelines do emphasize the role of some of the other ways we do this, like team-based care, when you have the luxury of having a dietitian, for example, or a good nurse practitioner, whatever, who can spend a few minutes with a patient going over their diet and saying, okay, look, the call out for Chinese with extra soy sauce, that has to stop. And having 3 margaritas every night, that's not a good idea either. So in that individualized approach to look at the lifestyle measures, the average guy or gal doing high blood pressure care, amongst all the other things that primary care does, is really hard pressed to have the time to do that. So the guidelines do mention the value of team-based care and shared decision-making when it comes to what should be done next. And I think those are some of the highlights that are in the current guidelines that make it a little bit more contemporary, that are really getting at some of the things we're able to do, especially the home blood pressure aspect.
I actually just recently spent a week in Copenhagen. Funny you mentioned that. And I have to say, lovely city for those who maybe haven't been there, and a lot of bike riding, which I'm sure is a good thing for blood pressure.
Agreed.
If we were to come back to the guidelines and kind of just think about the different classifications of elevated blood pressure and maybe some of the big buckets of people that you might see with increased blood pressure. When someone presents to you, in what situations are you saying to that person, okay, I'm recommending for you just go away and focus on lifestyle, A, B, C, D, and I think that could be enough, versus someone that comes to you and you're like, your blood pressure is at a level where I think that you need to commence medications straight away with some lifestyle modifications as well?
Yeah, good question. And it's faced all the time. So let's back up for a second and just, if we're going to use information, we have to have good information. So that old garbage in, garbage out, that is so true in high blood pressure care, because it is so easy to do a bad job at measuring blood pressure. If you measure it too quickly, if your feet aren't supported, if your arm's at the wrong place, if your bladder's full, if you just had a cigarette or a cup of coffee, there's a dozen different things that can screw up a measurement. And almost all the time, Simon, when the errors occur, they raise rather than lower the result. So most times you get a falsely elevated blood pressure type reading. So my first pillar in doing high blood pressure care is to make sure we're dealing with good information. And we know that some people, and it's a debated figure, but a safe figure is 15 to 20%. Some people, just when they go to a doctor's office or have it measured in a clinic, even in a part of a hospital or whatever, their blood pressure goes a little haywire because they're scared to death of what they're going to be told. And then you weigh them and tell them you're overweight. And then, you do other unsavory things, and you stick them in a room, it's cold, and then you slap this blood pressure cuff on them, and guess what? It's 145. So, making sure that not only is the blood pressure done correctly, but whenever possible, looking for a blood pressure outside the office so that you can be relatively sure that what you see in the office outside the office is still high. We call that a white coat effect or office hypertension. There's a lot of debate over what the best terminology is, but everybody sort of knows that there's, every time I go to the doctor, the dang thing's elevated. So when you're able to check it outside the office, whether you wear a monitor for 24 hours or whether you invest in a blood pressure cuff and measure it at home, it's helpful to know that it's truly high outside the office. Because once you commit someone to a therapy, whether it's lifestyle or more importantly, a drug therapy, it's usually for life. Most blood pressure is what we call essential or primary hypertension. You got it because you got it. Your parents probably gave you some tendency toward it, and you probably contributed to it by virtue of your lifestyle choices. So once you're treating it, you're usually treating it for a good long time until, maybe a person loses a lot of weight, or they take Wegovy or Ozempic or something and they lose a lot of weight. But in the absence of a great deal of weight loss, most times it's there to stay. So when do we push the trigger and actually treat it? And there it becomes something of a numbers game. When blood pressures are 130 to 140 for the upper number or 80 to 89 for the lower number, we call that stage 1 hypertension now. That's a paradigm shift that occurred with the 2017 guidelines labeling that hypertension. When that's the case, if All other things seem reasonable. I mean, they're relatively young, they're physically active, they haven't had a heart attack, they haven't been admitted for heart failure, no evidence of cardiovascular compromise. We measure risk factors for all those things, cholesterol, glucose, kidney function, that kind of thing. But in the absence of that, we'll try the lifestyle measures. But if they're already at ideal body weight and their resting heart rate is 58 and they avoid salt like they avoid the plague, there's not a lot of benefit you're going to see with lifestyle measures. But most people are not so gifted in terms of their lifestyle choices. The average person in America is a little heavy. And so we'll try the lifestyle measures and we commit for a period of time. And this is the important thing. We have a contract with the patient that says, okay, we're going to give this 6 months, 3 months, whatever you think is reasonable. But at the end of that time, you have to be prepared to move on and start something, because we do aim for values less than 130 when we can get them safely in our office practice or in our at-home, as long as we can trust the at-home blood pressures are done correctly. So 130 to 140, we'll give it 3 to 6 months with lifestyle. What do we aim for in lifestyle? Weight loss if overweight. Sodium reduction if they are an average American, eating roughly twice the amount of salt we really need. Enhancing potassium intake when we can. One of the most overlooked things is if you happen to use a salt shaker and you have good kidney function, using a salt substitute, actually like a potassium chloride, may not quite be as savory as sodium chloride, but it's healthier for you as long as your kidneys are okay. Alcohol, we recommend 2 for a guy, 1 for a girl, and exercise. And we can do it the whole 2 hours on exercise alone, because there's so many flavors of exercise. But it's sort of like, Washington, D.C., everybody kind of knows where it is. So exercise, everybody kind of knows that it's a good idea periodically to actually do something for the purposes of your health that makes you break into a sweat and raises your heart rate a little bit. When we fail, and we often do fail, then we start meds. If they're 140 to 160, the typical thinking is to do meds and lifestyle side by side. But, we go kind of easy at first, because most of the time, these are people that are in their 30 to 60 age range and often not much in terms of additional risk. When it's 160 or higher, it's mandatory. We should treat that. No question about it. Remember that risk proportional to every 20 millimeter increase in systolic? Now we're dealing at 4 to 8 times as much blood pressure related risk. So we treat that. And with 180, it's a judgment call whether even to admit someone, depending on whether they have some shortness of breath, pressing chest discomfort, or some other thing that makes you think there's an impending target organ collapse here present. But we kind of graduate that. And most of it's based on what we think the systolic pressure is up to. More so, I think, than diastolic. But 80 to 89 is our diastolic for stage 1. Above 90 and above is our diastolic for stage 2. When the diastolics run more than 120, we get concerned, because that is real tightness, and the coronaries and the brain and the kidneys can be affected by that degree of vascular resistance. And so we're usually thinking pretty hard about how aggressively to manage that. If we have a really reliable patient who can come back maybe twice a week for the short term to make sure we get blood pressure going in the correct direction, and who can measure it at home, we'll do an outpatient approach as long as there's no sign of something about to have a catastrophe in their circulation. But when it's not the case, we don't know them and they look sick, and maybe there's some change, subtle change, or even obvious changes on their cardiogram, electrocardiogram, heart rate, heart rhythm test, then we not uncommonly will admit them to the hospital to make sure we get things started to manage their blood pressure. But honestly, Simon, that's uncommon anymore. Most of the time, people have had at least a couple of blood pressure checks in their life, because the message about checking it in an office practice when they come in for, their get their cast off, or a well baby check, or, we even check kids now, or even such things as like managing their gout or some other thing. We typically a blood pressure is going to get done, and when it's elevated, attention's paid. I think that exercise is helpful as second in all for the following reason. When you exercise, a couple of things happen. Number one, you burn calories. If you've got a lot of energy stored in your fat tissue, then you either reduce the intake of energy, so less calories, or you increase the usage of the energy. That's where exercise comes in. So exercise is helpful as a component to a weight loss regimen. Eating less and expending more, that's the magic in terms of a non-drug approach to weight loss. So it's good for that. Second thing exercise is good for.
I recently ran my full labs through Function Health, and I have to say the results were eye-opening. Turns out my ApoB was higher than ideal, probably thanks to a little too much coconut yogurt. I also found out I was slightly low in copper, something that I would have never suspected without testing. On the flip side, my biological age came back 13.3 years younger than my actual age, a calculation based on the work of aging researcher Dr. Morgan Levine. So all in all, I've got a few tweaks to make to optimize my lipids and nutrient status, but overall my blood work says I'm doing pretty well. That's what I love about Function. You get access to over 160 biomarkers covering everything from hormones and inflammation to nutrients, toxins, cardiovascular risk, and more. And all your results are housed in one beautiful platform, all tracked over time. Once you get your results, you can make informed changes before small issues become big ones. To get started, head to functionhealth.com/Simon Hill. The first 1,000 people get a $100 credit toward their membership. That's functionhealth.com/Simon Hill. Right. So if you have a patient that presents to you, let's say they're late 40s or early 50s, and their blood pressure reliably is sitting in the kind of maybe mid 140s or 150, that would be a conversation of perhaps they do medication plus lifestyle. But if they were someone that, let's say, was overweight, was smoking, was drinking a lot, was consuming a diet that had a lot of salt, and they were kind of very committed to making lifestyle changes, in that instance, you could send them away and say, hey, okay, if you're willing to make kind of aggressive lifestyle changes, you might be able to get this in control without medications?
In general, I wish I could say, I mean, that sounds real good, but in real life, it often isn't all that effective. So what I tell patients, if I happen to be the first one to take a crack at managing their blood pressure and they come in, like you said, 145 to 150, they're 40 years old, I'll tell them, look, you need to be treated. We're going to start both medication and lifestyle measures. Your BMI is 32. Your target BMI is 24. You're about 50 pounds overweight. You lose those 50 pounds, we'll revisit the meds. And weight is our biggest win when it comes to high blood pressure care, because weight loss is probably the single most important factor from a lifestyle, non-drug standpoint to lower blood pressure. And so I put it out in that particular way. I'll reconsider the meds. And, I've had a couple of patients that have lost the 50 to 60 pounds. They almost always had an incentive. They wanted to get into a tux and look nice for the kid's wedding. Okay, that's one incentive to lose lots of weight, and maybe you have 8 months to do that. Or they've had oral surgery and their jaw's been wired shut. They can't eat. It's another time I've seen that kind of weight loss. And now with the things called the GLP-1 receptor agonists, the Ozempics, the Wegovys, the Tides, tetraprotide, semaglutide, there's even clinics for this. That kind of weight loss has some blood pressure improvement associated with it. I'm not recommending that right on this because there's a whole discussion that has to take place for that, let alone how much it costs. But that aside, to answer your question, I do both. And I offer to back off on the medication if they can do the lifestyle changes. But, honestly, Simon, I'm kind of a Calvinist at heart. I believe that people are inherently not as good as they think they are. And consequently, even the most highly motivated person, I don't want to waste 6 months to a year waiting for their blood pressure to come down when it sits at 150 for a year. I just don't think that's a great idea.
And coming back to what you said earlier, at least your approach is aiming to get that person below 130, but you said the new guidelines, and there might be some people out there that are suggesting that, well, it might be better to get them under 120 if they're someone that's high risk of cardiovascular disease.
Yeah, so that's in the current guidelines. I won't say that it's, on every page so that, when you really want to get a message across, you kind of insert it in multiple sections so that the guidelines are 100 pages long, right? Who sits down and reads 100-page PDF, especially when it's single spaced in two columns? So, if you're going to put something in there that you really think is important, you kind of put it in several sections, either under diagnosis, under management, under special circumstances, under really bad blood pressure control, that kind of thing. But when you look at the recommendations for doing the less than 120, my concern for that particular recommendation is it's based largely in studies, almost exclusively, in studies done in China. And that's fine. I mean, Chinese know how to do clinical trials in hypertension. This is not a criticism of an Asian population study where high blood pressure has been the target, 140 versus 120. What bothers me about it is that pure Asian, especially populations, have a different outcome profile for blood pressure elevation compared to the mixture of peoples that we have in the US. And stroke is a big one in China, especially. So stroke benefits are remarkable when you lower blood pressure. And the stroke and the heart failure are the two biggest wins when it comes to treating high blood pressure and looking for improvement. The other problem, not the other issue with the 120 with high cardiovascular risk is much of the three studies, 1.5, are diabetics. And so diabetics are a population where we know the risks are enhanced because you've got now another risk factor besides hypertension that collude with one another, because diabetes and high blood pressure both attack the circulation through independent processes, but also because they're interlinked. If you're diabetic, you have twice the likelihood of hypertension. If you're hypertensive, you get twice the likelihood of developing diabetes. So when you have partners in crime like that, it's a different issue than just generic hypertension alone. So when you base recommendations on that kind of epidemiology, even though it's clinical trial data not done in the US, I've got an issue with the feasibility of getting to those levels because the Chinese look a little more drug sensitive to me. We usually need 3 or more drugs to get below 120 in the US, but the Chinese can do it with 1.5 to 2 drugs. 1.5, that's an average. So some are on 1, some are on 2. But the sensitivity of the Chinese populations to blood pressure medicine looks a little bit more, they are more amenable to blood pressure reduction with the pharmacology available. They're the same drugs we have. They just seem to respond a little bit better than we do in the US because, is a Black American the same as a Chinese American, the same as a Hispanic American, the same as a white American in terms of the likelihood of not only blood pressure reduction, but benefit from blood pressure reduction. So we have populations of risk that are at higher risk. You take a Black American and a white American, same age, same gender, and you lower the blood pressure on both, you're going to get more benefit in general in the white compared to the Black American because they are inherently at greater risk. So the ethnos that are present in our population are different in terms of outcomes. And that's why I just am a little concerned about reaching a 120 millimeter systolic blood pressure goal when your prevent risk is more than 7.5% in the coming decade.
The reason I asked that question was I'm sure there are many people listening to this show that are having this conversation with their doctor. And what I'm taking away is that would you agree, would it be the case that most physicians, at least in the United States, if they're dealing with someone who has blood pressure of 150, 160, they would be having a conversation with that patient that what they're trying to do is at least initially get them below 130? Is that the kind of the shared goal?
Right. Getting below 130 is step one. Getting below 120 is an option that I think you can exercise. If you get them down to 126 to 130 on maybe 2 drugs and they feel okay. I mean, hardly anybody's going to feel great taking 2 medications for blood pressure, but maybe you get lucky, 1 or 2 people that do. That said, if you think you can reasonably lower it the extra 6 to 8 points to get them to 118, 116 without causing them to be excessively dizzy, without nausea, without falling asleep in the middle of the afternoon, and a number of the other things that patients over the years have told me about. I know the drugs are helping, but I have this concern about them. So if you think you can add or titrate, get a little bit more of something to get them a little further down the systolic line to less than 120, and they have high cardiovascular risk, that's the population that I think you're going to get the biggest likelihood of not only achieving that, but keeping them on it. Our biggest, at least to me, the biggest challenge we have in high blood pressure care is not that we don't have enough medications or ideas about lifestyle for it to work. Our biggest challenge is keeping people doing it. Keeping them on their meds, keeping their weight down, keeping the exercise at how many minutes a week, whatever it is. When you first do that, it's like, okay, I'll do it. But after a year or two, it gets a little more challenging to stay the course. And that's where the cheerleading aspect of blood pressure care comes into play.
Yeah, and it goes back to what you mentioned in our last episode, specific to adherence, the importance of listening to the patient and understanding their individual experience so that they feel connected to you as a physician, as someone, a carer, and trusting the information that you're providing them.
Absolutely essential.
So just to double click on the medications here, Raymond, what do you wish patients or physicians understood when it comes to the kind of suite of medications that exist to lower blood pressure? And this is an area of science that's evolved over decades. When we look at these new guidelines, what do they make clear about, whether it's diuretics or ACE inhibitors or ARBs? How are we approaching this problem of lowering blood pressure or elevated blood pressure from a pharmacology point of view with the things that you've raised in mind, which are treatment goals and symptoms? What would you say is kind of like the best practice way of navigating this?
So we kind of teach the ABC approach to blood pressure medications. My premise, my a priori here, is that the average person, when you're going to treat the blood pressure with medication, often is going to need 2 drugs. Wish to heavens it was possible in the majority of people to treat him with 1 medication. Sometimes it's possible. When you start at 134, odds are you're going to get below 130 with a single med. But once you pass the 140 mark, the average blood pressure med lowers your upper number by 10 to 12 and your lower number by about 8. It wouldn't get approved if it didn't probably meet those standards, and the company that manufactures it did the testing to show that it does that, especially compared to a placebo in an 8 to 12 week time period in a double-blind and randomized fashion. That said, what are the A's? So the A's are the angiotensin system blocking drugs, ACE inhibitors and angiotensin receptor blockers. Years ago, when Nancy Brown, the chair of medicine at Vanderbilt, came to our institution to give a lecture on hypertension, this issue came up. What do you use first? We think blocking the angiotensin system, the renin-angiotensin system with drugs, ACE inhibitors or angiotensin receptor blockers, called ARBs for short, seems to be a good idea. Lots of data to show benefit, generally one among the best tolerated of the blood pressure medication classes. So she said, how many of you use an ACE inhibitor first? In the audience, some hands went up. How many of you use an ARB first? Other hands went up. How many of you are cardiologists? The same ACE inhibitor hands went up. How many of you are nephrologists? The same ARB hands went up. So cardiac-centered approaches to blood pressure care, typically you'll pick an ACE inhibitor. Kidney-centered blood pressure care, often we use an ARB first. What's the difference between the two? ACE inhibitors do a little bit more than interfere with angiotensin. They do things with a hormone called bradykinin that may be beneficial. Angiotensin receptor blockers do not have the most common side effect of an ACE inhibitor, which is a dry cough. So cardiologists love it because there's tons of data in cardiology on ACE inhibitor use. Nephrologists like ARBs because some of our most important clinical trials in diabetic kidney disease were done in the late 90s and early 2000s. And they were both done, 2 different trials with ARBs. So nephrologists tend to use ARBs, cardiologists tend to use ACE inhibitors. What do we add when you're not at goal? So in general, we usually add a diuretic because diuretics and ACEs or ARBs are complementary. For example, use a diuretic, your renin system becomes more active. So if you've got that blocked, now you get a little bit more bang for your milligram with the diuretic than you did just using the diuretic by itself. Others like long-acting calcium channel blockers with the ACE inhibitors because the diuretics do a little bit of damage to glucose control. Diuretics can raise your uric acid and cause the occasional gout episode, which is not pleasant if you happen to be that 1 or 2% that gets gout in terms of that kind of therapy. So long-acting calcium channel blocker tends to be nice. And the most common side effect of those is swelling around your ankles, which is lessened when you use an ACE or an ARB with it. So we trade the complementary mechanisms of action, how they lower blood pressure, and also the trade-off in side effects, because diuretics lower potassium, but when you have an ACE inhibitor or an ARB, the potassium loss isn't as great. So that combination makes sense. The long-acting calcium channel blocker, ACE ARB, that makes sense. So 2 drugs may control 60 to 80% of people with high blood pressure. And when you come to that point where you're on combination of the 2 and you're still uncontrolled, we add the one that's missing. So if you're on the diuretic ACE or ARB, we add the calcium channel blocker. If you're on the calcium channel blocker, ACE or ARB, we add the diuretic. And at that point, if they're still uncontrolled, we find our friendly neighborhood hypertension specialists and off they go. Because when you're at that point, if you really believe they're taking the medication and doing as much a credible job as they can in controlling their salt intake and doing the other heart-healthy things that are lifestyle control, so it usually helps to have another set of eyes look at this and have the patient hear from a, quote, authority on hypertension, often a cardiologist, a nephrologist, or an endocrinologist. All 3 specialties tend to put the sign out for hypertension underneath whatever their subspecialty is. And then having the extra set of eyes, maybe a test or 2 that wasn't thought of. Sometimes you're a little better at lowering blood pressure than this triple drug combination of the A, B, and C drug type things will get you. It's actually A, C, and D. The B is a beta blocker. We tend not to use beta blockers as much earlier on in blood pressure care now as we used to do in times gone past.
Okay, so to kind of throw that back to you, most commonly someone is on an ACE or an ARB.
Yep.
And then possibly in combination with a diuretic or a calcium channel blocker.
Right.
And then often, if that's not enough, the other additional medicine is added, be it a diuretic or a calcium channel blocker.
Right. That's our standard triple therapy. And we have tablets that have all 3 medications in them so that you could take 1 or sometimes 2 of those single tablets a day that have all 3 medicines in them.
I've had a bunch of friends ask me recently, Simon, do you actually rate 8 sleep? So here's the truth. I would not promote 8 sleep if it hadn't genuinely helped me. It has literally transformed my sleep. Since adding the Pod 4 Ultra and then more recently the Pod 5 Ultra to my bed, I've been waking up feeling fresh, clear-headed, less inflamed in the face and fingers, and ready to take on the day with enthusiasm, rigor, kindness, and patience, all good things. That's what a proper night of recovery does. It literally makes me a better human. The Pod 5 isn't a mattress. It's a high-tech cover that fits over your existing bed. It personalizes the temperature on each side, tracks your sleep stages, and even detects snoring, gently adjusting your position to help stop it. And now with the new Pod Blanket, that same intelligent temperature control extends across your entire body. It's like sleeping in a cocoon that actively helps you recover. This is hands down one of the best investments I've ever made for my health. Head to 8sleep.com/theproof and use the code THEPROOF to get $350 off your Pod 5 Ultra. And you've got 30 days to try it. And if you don't like it, which I can't see happening, send it back for a full refund. Shipping to many countries worldwide. See details at 8sleep.com/theproof. What would you say, Raymond, and I'm sure you've come across this, I've seen various comments online where people have a view that, and this is the same for cholesterol, where they say, over the years, the guidelines have lowered the treatment threshold and doctors just want to prescribe more drugs. And then the guidelines have simply lowered the thresholds in order to create a pharmaceutical industry that's more profitable.
Well, since all the drugs are now generic, we no longer have the trade name advantage. So if I'm a drug manufacturer and I make a hypertension drug, Hypertenx, and now I can sell it and maybe charge $100 or $150 for a month's supply. Once it goes generic, you're looking at $5 to $10 for a month's supply. I'm making the numbers up, but they're roughly proportionally what the differences are. At this point in time, we have generic ACE inhibitors, we have generic angiotensin receptor blockers, generic long-acting calcium channel blockers, and generic diuretics. So there's no longer an industry incentive here to be prescribing meds. We also have literally millions of patients treated for blood pressure to reinforce the benefit of blood pressure reduction. And so we've got good data on blood pressure reduction and benefit, and we no longer have the economic incentive that might have been present in years gone by to treat with specific ACE inhibitors or specific angiotensin receptor blockers. So I think the pharmacologic aspect of blood pressure therapy is dwarfed by just the current realities that we have. We have lots of generic meds. And, it's usually possible for a reasonably small amount of money a month to treat blood pressure. And the blood pressure monitors now have gotten pretty good, and you can get a decent one for anywhere from 60 to 80 bucks or so. And those give you a good sense of how well your control is maintained at home, which is really an important aspect that I think we often undervalue.
And in terms of troubleshooting symptoms or side effects that someone could be experiencing from a medication or multiple medications, you've mentioned a couple of things that you'd be thinking about. Is there anything outside of the medication that they're taking and potentially changing that, or the dose of that medication? Is there anything outside of that you would be thinking about that could help someone manage symptoms?
There's a couple of things we do. Sometimes it's not the med, it's what we call the excipients. So when you make a pill, let's say you go and you're on lisinopril, a standard ACE inhibitor, and you go to your pharmacy and you get a little bottle full of lisinopril tablets. Well, each tablet, each 20 milligram lisinopril tablet is not 20 milligrams of lisinopril and that's it. It's got magnesium stearate and citric acid and all these other things to make it into a pill. And so it holds its form with the 20 milligrams of lisinopril in it. So we have 10 or 11 ACE inhibitors out there. And if you develop a problem with lisinopril, other than the cough, all the ACE inhibitors cause cough. But let's say you have something else. I don't know, your ear buzzes or something, and you think it might be the lisinopril. You can switch to trandolapril or one of the other prils. And in that circumstance, the excipients are going to be different, and you may see the symptom abate, or it may be due to the ACE inhibitor approach. So we usually, if we have a good response, but we have a side effect, we're going to try and maintain that good response by an alternate agent in that same class. And sometimes it's just related to the compounding in the pill itself. So we'll try that. The other thing is that we know some symptoms are just class-related effects. So the edema, the swelling in your ankles that's associated with every one of the long-acting calcium channel blockers, variable degrees, granted, but nonetheless, it happens. And the marker for it is that your ankles aren't so swollen when you get up in the morning, but by 3 p.m, you have Italian grandmother feet, the swollen things that look like pillars. And so that is a standard, what we call dihydropyridine calcium channel blocker side effect. And it may be that if you need another agent, you can add an ACE or an ARB, you're going to have reduced by 50% the likelihood of that swelling being such a problem. It doesn't erase it, reduces it by a half, but nonetheless, there's the other half where it still stays. In that sense, we give up. If they can tolerate it, it's not a health hazard by and large. It's just cosmetically unsightly. It's hard to wear high heels when your foot is slipping all around the sides of your heels. So in that circumstance, we'll stop the drug or we'll try a dose reduction. Once in a while, dose reduction will reduce the side effect. And honestly, Simon, sometimes people they get more tolerant of the side effect. We always kind of hope for that because most side effects that we still try and keep the drug in play are annoying, but not life-threatening or limb-threatening or organ-threatening in terms of their effects. So the management of side effects, that's where I wish I had done a psychiatry residency along with my internal medicine residency. Because sometimes some people are they have physical symptoms. Like I said, we listen to them, we try and be empathic and hear them. But, when you're on your fifth class of medication and the person has the same side effects on every single thing you do, it's really hard to believe that it's truly the drug in each case and not some psychological component to the drug in each case. And it's not easy to just say, I think you should see a psychologist about this particular thing, because that breaks the physician-patient trust issue. They now think you think they're a crock or some other equally pejorative term. So, trying to manage side effects, especially when you're at a place like Penn where I work, and you have patients who come in on 4 or 5 drugs and they don't feel good in the first place. And you sit in there thinking, which of these could be responsible for that? And how am I going to manage this when they're still high and I need to do more for their blood pressure, not less, in terms of taking meds away? So it becomes an individual case-by-case kind of thing. We know there are certain side effects that we expect, some side effects that can happen, possibly related, and then there's some things that just, there's a psychological component here. I got to really deal with that if I can, and maybe uncover 1 or 2 things that might be leading to that sort of thing, steering the person away from blaming the med and maybe blaming the fact that they have underlying COPD, chronic obstructive pulmonary disease, and that's why they're coughing on the angiotensin receptor blocker, which typically doesn't have cough as a side effect.
Yeah, well, I have to imagine that keeps medicine interesting, dealing with humans who are complex, not just treating biology and data points.
Yeah, it's challenging. Day by day, it's challenging.
Coming back to lifestyle, and I know my audience is going to be super interested in this. So you mentioned that weight loss is probably the biggest lever from a lifestyle point of view that someone can kind of pull to bring their blood pressure down. If you had to, just at a high level here, kind of rank the top 2 or 3 lifestyle levers in order, their magnitude of effect on blood pressure, weight loss being number 1, what are number 2 and number 3?
So they vary a little bit because some people are more benefited than others by some things. So let me give an example. If I have a Black American, 50% chance they're salt sensitive. If I have a white American, 20% chance they're salt sensitive. So the likelihood of blood pressure reducing by virtue of reducing sodium intake is higher in my Black American patient than it is in my white American patient. So I'm going to emphasize it more in the Black American. I'll emphasize it, but not to the same degree in the white American. So, but in general, I think that exercise is helpful as second in all for the following reason. When you exercise, a couple of things happen. Number 1, you burn calories. In order to lose weight loss, if you believe Newton's second law, I think it's the second law of thermodynamics, you can't create energy. You can just change it from one form to another. If you've got a lot of energy stored in your fat tissue, then you either reduce the intake of energy, so less calories, or you increase the usage of the energy. That's where exercise comes in. So exercise is helpful as a component to a weight loss regimen. Eating less and expending more, that's the magic in terms of a non-drug approach to weight loss. So it's good for that. Second thing exercise is good for is that it improves things like your blood sugar and your triglyceride level and the good form of cholesterol, which we call high density lipoprotein, or HDL for short. So exercise gets you a little bit better what we call profile, glucose and lipid profile, because it improves the ability of insulin to work as insulin was meant to do. Insulin helps your glucose to be stable. Insulin keeps your triglycerides in the cells, not circulating. And insulin's also good for not raising your HDL cholesterol. So when you need less insulin to do its job, your HDL cholesterol tends to be better. And for guys, one of the only things we can do to increase our HDL cholesterol is to exercise, short of drugs. And the third thing is probably, I don't know where to rank it with the other two, but exercise improves your heart rate. And the reason I've mentioned before that the two things that damage elastin is the stretch and the number of heartbeats. If you exercise, for the time you're exercising, your heart rate goes up, but your resting heart rate comes down. That means that there's fewer heartbeats around the clock. And I think one of the other things about the pulse rate, aside from the fact that it's sort of fun to capture it on your Apple Watch or your Fitbit or your Oura Ring or whatever, is that when you look at the relationship of the heart rate to longevity, it's dang near as good as the blood pressure to longevity. So lesser heart rates, people tend to live longer. So exercise is useful for that as well. I rank alcohol fourth behind salt. So weight loss, exercise, salt, alcohol, and then potassium intake.
On exercise, Raymond, as a nephrologist and from a blood pressure perspective, do you have any views on the type of exercise that is most effective, be it, going out and doing a kind of steady state run or bike ride or doing sprints or lifting weights?
So I can tell you what I do. So this is one of those things where what does he say versus what does he do? My goal each day is 12,000 steps. And I try at least once and often twice a week to get to the gym because I see a cardiologist and he says to me, what do you do that, causes you to break into a sweat with exercise? So that's where the gym comes in. The walk doesn't, but the gym does, unless the walk's in the middle of August and it's 108 degrees outside. So I think that steps are something that mostly everybody can do. You don't have to jog. You don't have to run. But if you do steps, you're burning calories. Every time you walk a mile, you burn roughly 100 calories. And so American Heart says 8,000, but I aim for 12 because I'm interested in more than just getting my heart into better shape in terms of my resting heart rate. I'm also trying to keep my weight from doing that, older age person thing where it just kind of rises with every decade. So I aim for 12,000 steps. I hit it most days. I used to be at 15, but I just have trouble getting to that level at this point. So I don't get my extra credit points now. That takes me almost hour and 40 minutes to 2 hours a day of walking in order to do that. But if you're going to invest in your health, it's better that than, watching some, Netflix, whatever, Amazon, whatever, some binge type of thing. So that's, when it comes to resistive exercise, like, isometrics and either bench pressing, I'm not as keen on those, mostly because I don't understand the benefits of those as much because they don't affect, if anything, they slow heart rate when you're doing them because of this Valsalva effect that people get when they weight lift or do isometrics. And there are people that believe a mix of aerobic heart rate increasing versus anaerobic heart rate reducing, like isometrics and bench pressing type things. A mix is probably a good idea. But I'm kind of the old school camp here, and I probably should be educated more about this, but I tend to do what I can do, which is to walk and try and visit the gym at least once, best case scenario, twice a week, 30 to 40 minutes at a crack when I get to the gym.
Yeah, I think that the guidelines call out a combination of both, perhaps being if someone has the time to do some of that cardiovascular exercise, the walking or jogging or whatever they can do at their level of fitness, and then some form of resistance training. And there was even things in the guidelines and some research that stood out to me that I thought was interesting. Some of those isometric exercises that people they don't need a gym or equipment to do. And I called out some of those in a previous episode, but I can perhaps put a link to that into the show notes because there are things you can do up against the wall at home or in the office without any equipment that seems to have a significant impact on blood pressure. Today's episode is brought to you by BetterHelp. October 10th is World Mental Health Day, and this year BetterHelp is shining a light on the people who make therapy possible, the therapists who have helped over 5 million people worldwide take a step forward. If you've ever done therapy, you'll know it's often the little things, the right question, a safe space to be honest, or a small win that shifts your perspective that can change everything. If you haven't tried therapy before, it can simply mean having someone to talk to when something is weighing on you. BetterHelp makes that first step easier. With the world's largest network of licensed therapists, strict standards of care, and a smart matching system built on more than 12 years of experience, BetterHelp helps you find the right therapist for your needs. And if it's not the right fit, you can switch anytime. If you're ready to find the right therapist for you, BetterHelp can help you start that journey today. Our listeners get 10% off their first month at betterhelp.com/theproof. That's BetterHelp, HELP.com/theproof. Salt. So you said salt was number 3 on that list, and perhaps more important for Black Americans than white Americans. Can you explain to us how does sodium salt affect blood pressure? What's the mechanism there?
Yeah, I'm sure there's a Nobel Prize somewhere for this, but it goes back to work that was done at the University of Mississippi in Jackson by a guy named Arthur Guyton. So Arthur Guyton studied dogs, instrumented dogs, and looked at the long-term control of blood pressure in this environment where all the dogs had ways to measure their blood pressure continually, and you could tweak them. You could give them a high-fat diet, have them gain weight. You could give them salt and look at the effects. But of all the things that have a long-term effect on blood pressure, many things affect blood pressure in the short haul. Caffeine, for example, will do that. Cocaine and illicit drugs can do that. They wear off pretty quickly in general. But the one thing that doesn't wear off is the tendency of sodium to cause blood pressure to elevate over time. Every liter of saline, blood without the red cells, just the blood, the liquid portion of blood, every liter of saline has 159 milliequivalents of sodium chloride in it. If your body is set up in such a way that you just happen to retain 1 milliequivalent of sodium per month, about 159. But over the course of a year, you would retain 12 milliequivalents. In 10 years, that'd be 120. This is 1 milliequivalent. You can't even measure that in terms of a balance study. If you put a person in a test tube and try and measure sodium in and sodium out, the precision in our ability to measure is not that good. So the kidneys do a marvelous job in most people of making sure that they put out in the urine each day or each period of time what you get in. And we vary our salt intake all the time. I mean, some days we have, light salt, and some days we just go nuts with the salt shaker and whatever, food you happen to like that is really savory and crunches because you've got so much sodium laid on the top of it. So that issue about a tiny bit of sodium retention over time, we think underlies one of the most prevalent theories about why high blood pressure develops in the first place. Because as the volume of the body expands, sodium chloride is the thing that gives your blood volume. It's volume. It's the salt that keeps all the water around it, that keeps your blood vessels expanded. If you have a problem getting that controlled, one of the ways you can get rid of that extra milliequivalent per month that you were retaining is to raise your blood pressure slightly. When you raise your blood pressure, that excretes a little bit more sodium in the urine. It's called a pressure natriuresis. Natrium is the Latin word for sodium. So when we say natrium, it means salt. And so that rise in blood pressure, a little bit of natriuretic out in the urine type of thing, and it reduces the body's sodium content. But you keep doing that over time, and then it's less efficient over time, and you can see how the blood pressure starts to creep in response to the sodium retention. That's one mechanism by which sodium causes blood pressure to elevate over time. That's the volume aspect of it. The other thing that sodium does is it makes every one of your constricting factors, so things like adrenaline that makes blood vessels squeeze, things like angiotensin, which you block with an ACE inhibitor or an angiotensin receptor blocker. But if you give a person angiotensin 2, their blood vessels squeeze immediately in response to getting that. And other hormones like thromboxanes and all this, there's a variety of vasoconstricting blood vessel squeezing type hormones in the body. And when you sprinkle sodium in there, they work more effectively. So the angiotensin 2 effect is enhanced when there's more sodium present. How do we know that? Well, we've done experiments where we've looked at the effect of angiotensin II on blood pressure, dose-related. Then we give them saline for either sodium tablets for a month or saline infusion. And then we look at the effects of blood pressure of the angiotensin II infusion, same doses, and now it's magnified. So we know that salt enhances the constrictor effects of other hormones, and it also increases volume, which in turn pushes the blood pressure up. So it gets it on both sides. Some people in the world are splitters. They want many little piles, and other people are lumpers. And when it comes to blood pressure, the lumpers say there's only two things in blood pressure, ultimately volume and the vasoconstriction, the resistance in the body. And so what sodium does is it bridges both camps. It gets volume side and it gets vasoconstrictor side. That's why it's helpful. I mean, if you have no need for salt, then taking salt in just kind of taxes your system. If you live in the middle of the Gobi Desert or someplace where your risk of losing salt through your skin, it's very helpful to have systems that conserve it. But we live in a society where there's free access to salt, and consequently, we don't need it. And we are predisposed to being a little thrifty with retaining sodium when we take it in, and consequently the effect of that is to raise blood pressure in people that are sensitive to the sodium aspect, either in the short term like the Black Americans, or in the long term like everybody we think has ultimately a role of sodium in their blood pressure at some point.
What's the difference between sodium chloride and potassium chloride, other than the obvious in terms of the mineral that we're talking about? But what's the difference in terms of the effect on blood pressure?
There was a decision made at some point about what the most important cation, positively charged ion, should be inside cell water or outside, the water outside the cell. We live in an osmotic environment. We don't live in pure water. We live in water that has a certain dissolved number of particles, the most important of which are sodium and chloride in the blood and potassium in the cell. So we have, if you measure your blood sodium level, Simon, it's going to be about 140, not the 159, because blood you're only measuring the sodium content in 93% of blood when you do the 135 to 140, because 7% of blood is solid. So when you look at that, it's the 140 milliequivalents per 930 mLs of blood. That said, when I measure it in your blood, it's 140. If I measure the sodium inside your cells, it's 8, 9, not 140. So what's making up the other positive charge in your cell? And the answer is potassium. So inside a cell, potassium is king. Outside the cell, sodium is king. And the magnitudes are about the same. So the relative plus outside the cell and inside the cell runs around 140 to 150 on both sides of the cell membrane. It's just that potassium is more important in the cell, and sodium is more important in the tissues and the fluids around your cells and the tissues that circulate the blood volume itself. When you eat potassium, you take potassium in, potassium has a couple of beneficial effects in the body. One thing it does is it helps improve the way the lining of the blood vessel talks to the muscle layer. So blood vessels have three layers: the lining, the muscle, and the outer layers. It's called the adventitia. What the muscle layer does is it waits for signals from the inner layer. It's called the intima. And one of the things potassium does is it helps the intima make the signals a little nicer, that relax, guys, we got this under control kind of thing. So potassium has a beneficial effect on what's called endothelium, because that's the name of the cells that line the inner lining. It has good effects on the endothelium. Potassium also has some other benefits. It reduces stroke risk in animal models of high blood pressure that are stroke prone. And so we think it's a good idea because when we measure the effect of dietary sodium on blood pressure, it's clear that in populations that eat lots of salt, there's a relationship. But if you look within those populations, the effect of sodium intake on blood pressure is mitigated by the amount of potassium. So we have a diet where we have a lot of sodium and relatively smaller amounts of potassium in most of our foods, because a lot of it's processed foods and sodium just tastes better. Honestly, it's a savory issue. But if you look at peoples that have very high potassium intakes and very low sodium intakes, a couple of Aboriginal tribes around the world, their blood pressure doesn't change across the lifespan, and it's normal. So the potassium and sodium balance in the body is what we really think is important now. And if you work on it by reducing your sodium intake and increasing your potassium intake, you help alleviate that component of the support for blood pressure being elevated. So we kind of emphasize potassium because of its benefits on the endothelial lining and its generic benefits in terms of outcomes like stroke.
So it seems that this is another kind of mismatch between our biology, which has evolved through adaptation over time, and the environment that we find ourselves in today. So at some point, hundreds of thousands of years ago, perhaps this like significant drive for sodium, kind of what you pointed out before, if you were living in the desert, served us in an environment where sodium availability was low. Whereas in today, we still have that same drive, biological drive and reward for sodium, but we live often in an environment where we're sweating less, moving less, and surrounded by very high sodium foods.
And the other side of it, Simon, is that if you look at a sort of agrarian approach to life as opposed to an urban, city dwelling approach to life, what does a farmer eat? Vegetables and fruits. Maybe meat is a luxury, but vegetables and fruits tend to be higher in potassium and lower in sodium. So a vegetarian will tell you that that's the way God planned it here, is to have that kind of intake as opposed to eating animal protein. I enjoy a nice ribeye, so sorry about that, but occasionally the animal protein I think is more satisfying from a taste standpoint. But it also makes sense from the fact that an agrarian approach, which, early human beings tended to be farmers, a lot of, susceptibility to the environment as a result of that. But that kind of intake favored potassium, and most fruits and vegetables are low in salt.
And then coming back to what you were saying earlier, so it's a twofold effect. We have higher sodium intake, we have lower potassium intake,
Right.
And the lower potassium intake makes us more sensitive, in a sense, to sodium.
That's the thinking, right. But that sensitivity does vary somewhat depending upon your ethnic background.
Gotcha.
The other thing, Simon, honestly, is that one of the things the sodium literature had as a plague on it is that when you look at the studies of salt sensitivity, one of the things we struggle with is what's the definition of being salt sensitive? How many millimeters of mercury does your blood pressure have to go up over what period of time to say that X number of milligrams or milliequivalents of sodium chloride, did that? Because it's sodium chloride that's the issue. Sodium gluconate, sodium bicarbonate doesn't have quite the effect. Sodium chloride, that has the effect.
Well, I think the colloquial definition of salt sensitive, Raymond, the one that I hear quite often is when people go out and have a night of lots of fried food and a lot of salt intake, and then wake up the next morning and you hear people saying, I have a salt hangover, or they feel puffy in the eyes and feel hungover.
Yep. They bought the economy size bag of potato chips and they were, watching Rings of Power on Netflix or something. And the next morning after they consumed, a 16-ounce bag, they have something related to a headache like that. Yep. That's not uncommon.
If we're thinking practically here to think about food swaps and what this means for the average person's diet. So I think earlier you mentioned the current person living in a Western country is consuming about double the recommended sodium intake. And so if we're thinking about solving this problem here and having the greatest impact on blood pressure, what I'm hearing is that you want to try and reduce your sodium intake. My understanding is that most of that's coming from ultra-processed foods, not necessarily the salt shaker, although that could be the case for some people. So it would be leaning a little bit away from the ultra-processed foods that are sort of high in sodium to make them taste good. And at the same time, eating more fruits and vegetables, which naturally contain more potassium, would seem like a very favorable kind of shift. What if someone is thinking, oh, maybe I can just keep my diet as it is and take a potassium supplement?
That's been done actually in some of the studies where what's the effect of just adding a potassium supplement to the diet? And it turns out the potassium supplement has some benefit, even though you don't change the background diet. So it's worth it to do that. But the caveat, two caveats actually. One is that when the kidneys aren't working so well, your ability to excrete a potassium load may be compromised. And potassium, if it rises in the bloodstream, potassium is very tightly controlled. The normal value is between 3.5 and 5. And that's a narrow range for most things in the body. So if you lose some kidney function, it still tries to keep it between 3.5 and 5. But if you throw a load at it by, a generous helping of a potassium related salt substitute in a meal, it could pop up over 6 or even 7. And the problem with potassium, the biggest problem, is there a problem with this? Yeah, the problem is that there's no symptom, no reliable symptom for high levels of potassium. So there's not something where you can say, oh, I think I should get my potassium checked because I feel X, Y, or Z type symptoms. Where potassium manifests itself as overtly high is when it stops the heart. And that gets most people's attention when that happens. But there may not be any premonitory signs. So that's why I'm always telling people the caveat of if your kidney function is normal about salt substitutes. The other thing is that ACEs and ARBs, they affect one of the hormones, aldosterone, that helps get rid of potassium. When you eat potassium, you can't store it anywhere, so you got to get rid of it. And controller mechanisms that do that, among other things, include a hormone from your adrenal gland called aldosterone or aldosterone, depending upon where you put the accent there. And ACEs and ARBs affect aldosterone. So you're not as able to handle a potassium load in some people when you're on those drugs. So that's why the moderate approach here, add some, but don't go crazy in terms of the amount, makes perfect sense.
And then the other swap that you mentioned earlier is swapping out regular salt potentially for a potassium chloride kind of low salt option, which are now pretty widely available in countries like America and Australia.
Correct. And the other thing, it does help to look at labels. I mean, what people often don't appreciate is there's a fair amount of salt in dairy products, for example. Ice cream, look at the labels on ice cream. I mean, it's just fascinating how it doesn't taste like salt unless you get the salt caramel type of ice cream. But in general, sodium content in dairy is pretty high. Pizza is notorious for salt. V8s, when we were doing a study where we had to get people on a high salt diet, a really high, over, about twice what the average American eats, we supplemented them with V8. We would give them little 6-packs of V8. It was a great way to push your sodium levels up for a short term, like a couple of weeks. I mean, we weren't trying to, create hypertension in the process. But looking at labels is extremely helpful. The goal, what are we aiming for? We're aiming for 2,000 to 2,500 milligrams per day. That's achievable most of the time. The 1,500 milligrams per day that American Heart Association and others touted, I never tell patients that because I don't think it's possible with what dietary availability we have to really get down that low without the help of a dietitian.
And some of the labels, or the foods, I should say, that I think kind of sneak up on people are the ones that you would think are healthy or relatively healthier, like falafel, for example. Sometimes you can buy falafel and there's like 1,000 milligrams of sodium per serve. Even some of the pasta sauces, the tomato pasta sauces that you can buy, again, they're kind of like the V8, where the base, you think it's tomato, so this is a healthy food, but the sodium can be very high as well.
Lunch meats are another source, and bread. Bread has salt in it. I mean, it's very enlightening to look at labels, especially good labels that have not only the fat and the protein and the carbohydrate, but also the minerals underneath it. And keep in mind, a serving is sometimes conservative in terms of what you consider a serving. So, having, 1 ounce of potato chips or so, that just, to me, I just put that aside. I know I'm going to eat more than that if I'm committed to having a bag of chips or something like that. But the amount of sodium in some foods is just really well hidden. Lean turkey is safe, but bologna and things like that, pepperoni, look at the labels. I mean, it's incredible.
Does someone need to worry about their salt or sodium intake if their blood pressure is currently 120 over 80, 115 over 80?
Yeah. I used to say, oh, don't worry about it. And then I met Graham McGregor from the United Kingdom. There's a thing called WASH, which was a movement in the UK to reduce the amount of sodium in food. And it was successful. And Graham McGregor was one of the forces behind that. And I was with him at a luncheon that the American Society of Hypertension held. And I went to reach, I'm embarrassed to say this, but it's a true story. I went to reach for the salt shaker, and he almost cut my hand off at the wrist. He says, what the, and insert your favorite expletive, what the blank are you doing? And I said, oh, I'm suppressing my renin activity, which is what, it's one of the clever things we argue for sodium intake. And he said, are you out of your mind? I said, well, my blood pressure's okay. He said, so what? Don't you realize that sodium also drives calcium out of your bones? And I'm like, oh, I didn't know that. And it turns out he's right. The sodium intake is linked to bone health in some, not everyone, but in some people. And it's enough that when you enhance your sodium intake, you leach some calcium out of your bone. So the answer to your question is, yeah, it does make a difference for some people in terms of osteopenia. Osteoporosis is a bone diagnosis. Osteopenia is what we usually see when we x-ray bones and say, oh, they look osteoporotic, but it's osteopenia. There's less calcium in the bone. That's the technical term for it. But yeah, there are health consequences to higher sodium intake over and above blood pressure. I have a colleague at the University of Delaware, and he's looked at the effect of sodium intake in people with chronic kidney disease who have normal blood pressure. And in a small amount, it doesn't affect the blood pressure, but it does affect the way the blood vessels respond to stimuli that should relax them. So they're less able to relax. That's called endothelial function. So sodium, I remember I mentioned before about that whole thing with potassium improving endothelial function. Sodium reduces endothelial function. It's another effect, and it can do that independently of elevating the blood pressure.
How do you feel about athletes who are sweating a lot and have normal blood pressure and are replacing using kind of an electrolyte mix that has sodium and potassium and magnesium? Are those types of supplements products safe for athletes at a certain dose?
I think that because we don't have, a queue at every Urgy center with people that have passed out or in a hypertensive crisis as a result of downing 2 liters of Gatorade after a vigorous workout. When you look at what athletes go through in terms of the periodic stress to their system, it's not like you're walking across a desert, the Sahara, and you have the same 24-hour type of circumstances that the body will adapt to. They have a limited time when they're going all out and they're sweating up a storm, and they're losing sodium through the skin when they do that. There's no question about that. And because it's isolated, they have a lot of time to recover, so they're not making permanent changes in terms of conserving salt loss through the sweat glands of the skin over time. They're doing it periodically, so they're still having a sweating episode. And by and large, they're young. And consequently, when you're young, the body is a little more tolerant of a lot of the things that we do, including if you take Gatorade or what's that called? There's some kind of water. It's like perfect water or something. When you take those water compounds with electrolytes in them, the kidneys function is usually pretty good in these people, and it'll handle the excess of any mineral that it doesn't need and excrete that, and it will also save the sodium that it does need in order to replenish what was lost through the skin. They can lose quite a bit of salt, so I generally don't have big reticence about that kind of circumstance in people that are pretty young and pretty healthy and do work up quite a sweat. So in general. But the idea of a 55-year-old overweight guy who's going out for a 1-mile walk, who takes a liter of Gatorade beforehand, that's where I would draw the line.
Right. Context matters.
Context.
In the literature, there's quite a bit of evidence on the DASH dietary pattern for lowering blood pressure. And in fact, it's mentioned in the dietary guidelines. What is it about the DASH dietary pattern that you think helps lower blood pressure? Is it that it's low in sodium and rich in potassium, or is it something else?
It's a mix of things, actually. You're right about the sodium and the potassium balance. It's crafted that particular way. It's also relatively low in some of the bad forms of saturated fat, for example. So it's specifically designed to meet both the fat issues as well as the electrolyte issues. Sodium is one of the many electrolytes to help balance the ideal intake of food. The thing about the original DASH diets, and people kind of forget this, is that the patients enrolled in those studies that ate the DASH diet didn't make the food. They went to a center, they got a cooler, sometimes twice a week. They took that food home. They ate only what was supposed to be in the cooler. No exceptions was the rule. And so that you had your diet handed to you. And so you didn't make the food choices. It was done for you. And you have very careful dietitians in the background making sure that the food is weighed and it's personalized to you. When you look at like a website that says how to follow a DASH diet, it'll have helpful suggestions for how to achieve the relatively low sodium concentrations in food and how to reduce saturated and trans fat and the other things that are considered bad for you. But the DASH diet, when properly applied, has almost as much blood pressure benefit as a drug. And so when you have especially the low sodium DASH diets, you get a 10 or 11 millimeter drop in the systolic blood pressure in people who are not on medications, but have blood pressures that are in the 130 to 140 range. So I think in that particular respect, it's good. It's hard to follow diets that are low in salt for the long haul. It gets back to that whole thing about the fact that people wear out when it comes to behaving. It's like being in a very strict school environment with your hands folded in front of you and paying very close attention to the teacher all day. Sometimes you just want a break. I mean, I want to go out and I want to have a spaghetti carbonara and I want to have 2 glasses of, Chianti with it. So periodically people are going to just break the rules. But by and large, the DASH diet is a good thing. The Mediterranean diet, which emphasizes olive oil, among other things, is also a good diet.
Yeah, and I think with these types of dietary changes, when you're changing an entire dietary pattern, at least from my experience, it's much more noticeable in the acute early periods when you transition from a diet that's loaded in saturated fat and salt and fried foods to a diet that is very low in sodium. That's a big difference acutely. But over time, like I can at least speak from my perspective, and my context and circumstances are different to everyone else out there. So take this with a grain of salt, pun intended.
Of course.
I found that my craving and thirst for salty foods is nowhere near what it used to be. That said, of course, I still, like you, I want to go out and enjoy myself and have the high sodium ice cream from time to time. But I think my body has adapted over time where it feels easier almost to eat a low sodium diet than it did early on.
Yeah. It's interesting because our drive to eat salt is not genetic so far as is known. Our sodium appetite is partly dependent upon what we were fed as a child. So if you had a parent that made your food, that mixed it up, and, this needs a little salt, and added a little salt to it, you're more likely to take that over in terms of your young years, your adolescent, and your young adult life. Salt intake is learned, not programmed, as far as we know. So when you reduce your sodium intake, especially if you do it abruptly, stuff tastes bland, absolutely bland, for a couple of weeks, maybe a month. And then suddenly it starts to taste okay. And then when you eat foods you used to just enjoy, now they're too salty for you because your systems change based upon your intake. So the sensory response is secondary to the intake. It's not that the intake is secondary to the thing here telling you, eat more salt. The things up here that determine your appreciation of salt through the salt receptors on your tongue are secondary to your intake. And so our ability to have our thresholds met for satisfaction from sodium intake are learned as opposed to programmed. It's fascinating.
If someone's listening and thinking, I'd like to first understand if I am someone who is quote unquote salt sensitive, so I understand how much these changes are likely to affect my blood pressure. Are there any biomarkers or tests that someone can do to say, oh, actually, I am a salt sensitive person?
There are a number of them. I won't put my quarter down and say this one's the best one of the group. But the simplest one is a measurement of a hormone we call renin. So renin comes from the kidney. In Greek, the kidneys are the renones, or renones. In Spanish, they're renones. And the renin is a hormone that the kidney makes. When you restrict salt, the renin will go up. When you give salt, the renin goes down. So one of the things that we use to look for salt sensitivity is that the renin, if it's low, is a marker of someone who's likely eating more salt, or at least their body is treating their sodium intake in such a fashion that we don't need any more if you got plenty on board. So anything you eat additional is not needed to have our circumstances met. And when you look at the renin activities in white versus Black American populations, for example, Black Americans are far more likely to have low renin activity because they're more salt sensitive than white populations are. And so that's one marker for it. Another marker is a very strange thing called 20-HETE, or 20-HEAT, for example. And this is a designer type of biomarker. It's not something that the average doc is even going to ever have heard of. But 20-HEAT sensitivity is another thing that marks your likelihood of being salt sensitive versus not being salt sensitive. And lastly, the ability of the salt intake to suppress the other key hormone in sodium metabolism, the one from the adrenal gland called aldosterone. We're at the point in medical care right now where we're beginning to realize that there are patients with high blood pressure whose renin is suppressed, and their body is telling you, we got plenty of salt on board, maybe a diuretic or something like that would be a good idea here, but their aldosterone levels are not similarly suppressed the way the renin activity is. So we're looking at a thing we call dysregulation, like disease. Well, this is dysregulation, so the Y instead of an I. But some people have an aldosterone or an aldosterone level that's squarely in the middle of the normal range. Normal range is about 3 to 15. Maybe they're 10. Meanwhile, their renins are low at 1, but their aldosterone is not low at 3. It's up there at 10, where it's saying that I'm still active, retaining salt for this person. And so that aldosterone to renin dysregulation is a kind of new thinking process that we're beginning to look more closely at as a means to understand why it is that some people are so salt sensitive, or better yet, are responsive, more responsive to blood pressure medicines that specifically interfere with aldosterone and its effects.
So is there a specific ratio that you would be looking for?
Right. So the ratio has been, unfortunately, a difficult concept for people to understand. We measure, when we see a new patient at Penn, and they don't have an obvious explanation for why their blood pressure is so hard to control, we usually measure aldosterone and renin activity. We don't usually apply the ratio until the aldosterone is clearly elevated, and that's usually above 20. So even though 15 to 17, depending on the labs, the upper limit of normal, we don't usually apply the ratio until it's over 20 for the following reason. Let's say your aldosterone is 10, right in the middle of the normal range, but your renin activity is 0.3. So when you do the 10 divided by 0.3, what do you get? You get a big number. But if you do the 10 divided by a normal renin of 2, you get 5. So that's a normal aldosterone to renin ratio. But if you happen to be a low renin person, now your ratio is elevated to the point where it's pointing to aldosterone as being the problem. I mentioned we're rethinking that whole paradigm, but in the meantime, to use the ratios effectively, they're driven mainly by the renin activity. So we don't usually use the ratio to say someone has an aldosterone or an aldosterone excess until the aldosterone level in the blood is clearly above the upper limit of normal. So we don't apply the ratio until it's over, the aldosterone level is over 20. And then we use the ratio. And typically the aldo's high and the renin's suppressed or even really suppressed. And that leads us to saying, okay, this person seems to have an aldosterone excess problem. And then we talk to them, because if they're willing to have surgery, we may find a tumor some of the time in the adrenal gland that makes aldosterone in the first place. Removing that tumor can help control their blood pressure, or even if they're young and recently hypertensive, even cure their blood pressure in some circumstances until the aldosterone is elevated.
I was just curious if there were any commercial tests that someone could quickly do that would say you're salt sensitive or not.
No great test for saying definitively on that. The usual test, I mean, the group at Indianapolis kind of set the bar here for us. They would take patients into their clinical research center, and these are all walks of life, on a Friday. They put them on a high salt diet for the 2 days and then check their blood pressure on Sunday night, Monday morning, and look at the difference when they came in on Friday versus when they go home on Monday morning. And they would put them on a high salt diet, and then they bring them back on a different weekend, and now they'd fill them full of a diuretic called furosemide, and they would salt deplete them. So you got the extremes, salt excess, salt depletion, and then they would look at the blood pressure responses on the 2 different regimens. And they would say that, oh, here's what you were high salt, here's what you were on the diuretic thing. If that's more than 10 millimeters of blood pressure reduction, you're salt sensitive. If it's not, you're salt resistant. And it was as simple as that. And they did thousands of patients at Indianapolis in years gone by to come to that conclusion. Other people have been a week-long type of sodium excess and then a week-long of severe sodium restriction. I've done those kind of studies in the past. There, you might argue that the difference could be as little as 5 millimeters of mercury different between the two, because now you've done it in a longer fashion as opposed to, hitting them with a 2x4. You're tapping them with a straw instead by virtue of 7 days instead of 2.5 days to get the response.
So if someone's doing this at home though, and let's say they swap their salt for a potassium chloride, they're eating less ultra-processed foods, they're eating more of a DASH dietary pattern with more fruits and vegetables, and they do have the at-home blood pressure cuff, and they're using it in a validated, reliable manner like you discussed in our previous episode, and over the course of a month, they're keeping an eye on their blood pressure and they're adhering to those changes, that would be long enough for them to start to see some changes?
Absolutely. So if you take your blood pressure twice in the morning, twice in the evening, for a period of at least 3, but preferably 5, and gold star 7 days in a row, that's your baseline. Then you make your change, whether it's less salt, more potassium supplement, less potassium supplement, more whatever, less whatever it is. And then you check again at the end of a month. That's certainly enough time. And by virtue of taking 2 blood pressure readings in the morning, 2 blood pressure readings in the evening for at least 3, better 5, and absolutely platinum if you do it for all 7 days, that'll really tell you whether that particular circumstance had an effect on you or not. That's enough data. I would argue that that's enough data.
You're taking all those measurements across a week, and then you're taking the average of is like your
Correct.
blood pressure for that week. Gotcha.
Right. Yep. So that's 28 readings, right? 4 per day, 7 days, 28 readings. That's a lot of blood pressure readings. And by doing morning and evening, you catch the normal circadian, the daytime variation in blood pressure by doing it that way.
That was actually one of my questions that I wanted to bring up later, but let's hit it now. How important is blood pressure variability, and is that an emerging area of science similar to if we're looking at heart rate variability?
It's a tough question to answer in a simplistic way, so let me try this. Years ago, I wrote an editorial piece on the choreography of the circulation, the difference between heart rate variability, which is good, and blood pressure variability, which isn't good. So you want your heart rate to be plastic, to be flexible, to change quickly. on any kind of circumstance, the fight or flight reaction. Oh my gosh, there's a saber-toothed tiger after me. I better pour it on here. I got to get my heart rate up to pump more blood to my legs so I can run faster. Blood pressure variability. Blood pressure is so well controlled by pressure receptors in your neck, carotid artery, and your aortic arch, and pressure sensors in your kidney that have to do with that sodium business I talked about before. So blood pressure variability, when you have your blood pressure doing all sorts of, highs and lows across 24 hours, that actually is more of a bad thing than having a blood pressure with less variability over 24 hours. And the reason why, at least one reason why there could be a bad side to having blood pressure variability, is that when your vessels stiffen with age and, many years of blood pressure and, use of cigarettes, presence of diabetes, lots of things affect blood vessel stiffness. Then the ability of these receptors in your neck, your aortic arch, their ability to dampen fluctuations in blood pressure becomes diminished. And consequently, you have wider fluctuations in blood pressure with activity, with sodium intake, with watching TV at a horror movie or whatever, and it happens to affect you. Anything that triggers a response, either in your involuntary nervous system or directly by some other thing that raises blood pressure, is less dampened, so that the excursions of blood pressure over 24 hours are increased. And years ago, a guy named Peter Rothwell from the UK showed that he was studying patients after strokes and things like that, but he noticed that the people that had the most fluctuation in blood pressure, the variability in blood pressure, were the ones more likely to have a recurrent stroke. And when you think about it, what those fluctuations likely tell you is that that person's response to stimuli that affect blood pressure and heart rate is affecting blood pressure more than someone else who's, quote, healthier. But also that when you look at visit to visit to visit variability in like patients that are seeing, a blood pressure doctor for 5 years, and you have 30 visits or some number of visits over those years, and you look at the variation in blood pressure over time, that's called long-term variation. If it fluctuates a lot, this is a person that may forget to take their medicines at times, or has wild fluctuations in their dietary salt intake, or periodically exercises and then becomes a couch potato and then periodically exercises again. They may do things that affect that. In the short haul, in a 24-hour period, blood pressure variability, again, is a marker, particularly of vascular stiffness. And so we look at that as a potential, this isn't good type circumstance, but I can't tell you in the same breath that we have great ways of reducing variability in blood pressure. The blood pressure medicines, they dampen the overall blood pressure curve. So, of course, they reduce variability because they reduce blood pressure. When you reduce it from here, the excursion, if it's this much, is now this much. But there's no good way to eliminate or to greatly reduce blood pressure variability that I know of that's been tested in a clinical trial fashion. And someone says, we absolutely need to do more about variability because here's the data to show it's beneficial.
Are you hopeful, optimistic that we're going to reach a point where there will be wearables that are measuring blood pressure for people in a less cumbersome way than the current kind of ambulatory blood pressure systems?
I am incredibly hopeful, but skeptical. And here's the skepticism. What we have currently, okay, so take a step back. How does a blood pressure monitor appear on the shelf in a pharmacy and says FDA something on it? Right. So the FDA has a process where they say to a manufacturer of a blood pressure measuring device, do you have validation data? No, I have no validation data. Well, why should we clear your device? Oh, because it's the same as, or similar to, very similar to, essentially equivalent to something you've already cleared. Oh, okay. You get clearance for that. So FDA doesn't ensure that even a standard thing in your doctor's office may or may not have ever done a validation study. So we don't know when blood pressure monitors purport to measure blood pressure, how good a job they do until we measure 85 people with 7 blood pressure measurements per person. One to set the scene, and then we alternate the device versus the standard, the device versus the standard, the device versus the standard. 7 blood pressures on that person. And we have 2 people blinded to each other that are listening for that to be the standard of the blood pressure effect. This validation difficult thing to do. You got to do 85 people. It's a lot of work, and it's not cheap to do that. And that's for the type of blood pressure device that is espoused by healthcare professionals saying, I will manage your blood pressure if you use this particular device and use it well. The wearables, on the other hand, like this guy here, or some of the ones that you stick your cell phone on your chest and it listens for it, or some of the ones where you press a photosensitive sensor to your skin and it measures the plethysmographic pulse of the blood as it comes into the tissues. They're getting better, but I don't think they're accurate enough to currently manage blood pressure, given the current constraints of they don't do a good job at trends in blood pressure over 24 hours or trends in blood pressure after you've made a change with the medication. They require recalibration, and that recalibration issue is the problem. If you don't recalibrate them frequently, they lose their ability to measure blood pressure. But I have a lot of confidence in the ability of smart engineers to overcome these shortcomings. I mean, there are people using radar in terms of measuring blood pressure, ultrasound to measure blood pressure. They can measure the pulse wave velocity in a segment of your brachial artery right inside here, a couple centimeters, and they know how fast the thing is traveling, and that's related to blood pressure. So there's a lot of interest in the wearables because, like you say, if you wear one of those cuffs that I've done a lot of work with over 24 hours, the thing goes off every half hour. And when that goes off at midnight, 12:30, 1 a.m., 2 a.m., 3 a.m., 3:30 a.m., it is hard to really believe that that was a good night's sleep, and those blood pressures during sleep are truly representative of what that person does. And plus, if you're a little chunky, like a lot of people are, you got to put the bigger cuff on. Bigger cuff, it hurts more when it goes off because you're squeezing with a big cuff instead of squeezing with a smaller cuff. So there's always shortcomings to our current ways of doing things. And I think there's a lot of hope in the wearables, but right now, and even with the current AHA, ACC, and you name it with an A in it, type of guideline that we have in 2025, there's a class 3, do not do this, to manage blood pressure. You want to do it recreationally? Go for it. But in terms of managing blood pressure, I don't think they're ready yet, but I think they will be in the not terribly distant future.
Coming back to some of these lifestyle changes that we can make, I have a number of questions from people in the community. So perhaps I can throw some of these extra ones at you as a bit of a rapid fire, and feel free to expand upon your answer where you see fit. Fermented foods. We've spoken about sodium. Fermented foods are like kraut and kimchi, often considered very healthy foods, but can be high in sodium. Do you have any particular views on fermented foods and their role in someone's diet?
As far as I can tell, Simon, the body treats sodium chloride as sodium chloride, no matter how it's filtered before it gets into you. So I don't have a strong feeling about the sodium aspect of those. There may be other things in fermented food that has health benefits independent of the salt that may outweigh the effect of the salt. But I don't have enough bandwidth in my set of facts up here to say one way or the other. I like kimchi, so, I do eat it, but I don't know enough about it to recommend it.
Me too, and I think it's worth underscoring, at least the stat that I've seen is about 80% of sodium in the average person's diet is from ultra-processed foods, not from
that's about right.
Fermented foods. So it's not that we're pointing the finger at fermented foods, but they are high in sodium. For someone who's trying to reduce sodium, they could be something to look at if they're consuming an unusually high amount, for example. Alcohol, you mentioned earlier, and this is in the guidelines, alcohol reduction being another way to lower blood pressure. How does alcohol affect blood pressure? Is it through its effect on calorie intake and body weight, or is there an independent mechanism?
So it's not really clear to me, Simon, how it does it, because there's a guy in Australia named Larry Balin who's been studying alcohol for decades. And alcohol has what's called a biphasic effect on your blood pressure. So if you bring a bunch of people into a clinical research center and you give them all, two jiggers of Jack Daniels at 7:00 at night, and they're all kind of social, etc. What you see is in the hours following acute alcohol ingestion, there's a drop in your blood pressure. It's on the range of 3 to 4 points. And then if you compare alcohol versus no alcohol to what happens the next day, 12 to 15 hours later, there's a rise in your blood pressure of about 5 points. So drop in 3, rise in 5, that's a net of 2. And when you look at what alcohol typically does to blood pressure in guidelines where they simply give you a chart, sodium intake reduces blood pressure 5 points. Exercise reduces blood pressure 6 points. Alcohol reduces blood pressure 2 to 3 points. It's usually at the bottom of the list of things that have an effect on blood pressure, because if you do an honest study of it, including 24 hours, not just the effects the next morning, you have a drop and a rise, and the rise outweighs the drop when you have at least a threshold amount of alcohol to see a blood pressure response. Alcohol may have things that it does in terms of lipids and longevity that may explain things like the French paradox with how they can eat goose liver loaded with fat and drink red wine and they live forever. How is that the case? Maybe there are sirtuins and other things in the red wine that help. So sometimes the trappings of what comes with the alcohol may influence the net effects. What epidemiologists have been worried about in the last decade and even the last 5 years in particular is that there appears to be a rise in cancer incidence, especially among younger people. And there's a concern, especially for GI cancers, that alcohol may be a component in that. So you see a 35 or a 40-year-old with colon cancer, it's like, wow, that's unusual. But, there's a fair amount of alcohol intake, especially in the US. So I always treat epidemiology associations with, my wife and I talk about this all the time, with a bit of skepticism, because people that tend not to do something often tend not to do something because they have a lifestyle that doesn't include that something. And it may be the lifestyle that's the benefit here, not the not doing something per se. And so it may be that they're healthier because they eat less salt and they run every day and that kind of thing. And they just don't have, tequila sunrise every particular evening, at least, or even several of them. So alcohol in the current guidelines, they're actually suggesting when possible, don't have any. And so that's more than I think some people are prepared to give up at this time. But it does make some sense from the epidemiology. I'm just a little skeptical that epidemiology is perfect in its ability to govern the recommendations that we make generically for all people. I mean, epidemiology is effects on groups. And when we take care of patients, it's an individual phenomenon.
And I believe, if I recall correctly, I think from the guidelines, the biggest benefit in terms of blood pressure lowering is if you're coming from like a higher baseline intake of like 6 or more drinks a day, and then coming down to that 1 or 2 mark.
Yeah, we've talked about this even amongst our group and our hypertension case conferences, because every once in a while you'll see someone that, claims to have 2 drinks a day, and they're having episodes where their blood pressure is nuts and they're in the ER. And it turns out they're actually binge drinking and they're having blood pressure crises afterwards because they have such high alcohol intake. That's not rampant and common, but it does happen. So there's clearly an effect, particularly at high levels of alcohol intake, not just on the liver with cirrhosis, but alcohol affects bone health as well. It's another factor that contributes to osteopenia in the bones. And it affects maternal health when you're carrying a kid during a pregnancy, and it can affect blood pressure.
So different to alcohol, where alcohol, you said, leads to an acute reduction in blood pressure, but then the next day or 24 hours there's an increase and there's a net increase.
Yeah.
Different to that would be the effect of something like coffee, which contains caffeine. My understanding is that will increase blood pressure a little bit acutely, but at least in the epidemiological studies that I've seen, coffee intake is not associated with hypertension, and there's associations suggesting neutral or a cardiovascular disease risk reduction. So when you think of coffee and caffeine, how do you kind of square all of that literature with regards to hypertension and blood pressure?
So every time something is published that implicates coffee in some bad outcome, Give it 2 months. There'll be 2 or 3 articles refuting that, showing the exact opposite. Coffee consumption is such a common thing that there are people that will just swear by it, and there are people that are just like, it's the wrath of God descending upon us in a hot beverage format. So I remember when I was a medical student, this article came out in the New England Journal of Medicine saying pancreatic cancer was caused by coffee. And then you looked at where the study was done. It was done in the waiting room of people in a GI practice. Well, that's a little selective. Why are they in the GI waiting room? Because they have symptoms that are leading them to a GI doc. And oh, by the way, they drink coffee. So you're looking at a very selective subset. And then there's tons of epidemiology since to dispel that notion. Coffee causes heart disease. Well, guess what? The filters especially tend to suck up some of the bad stuff. So when you put coffee through one of those paper filters, it tends to have less effect. And consequently, when you look at blood pressure, when you look at heart rate, when you look at a bunch of things, you take a step back and you say, what has industry done over the last 100 years that really has been a key element of effectiveness? Coffee breaks for their workers. Why? Because coffee increases efficiency. Coffee helps people think better, it gives them a little extra energy. And yes, short-term coffee usage can raise blood pressure and heart rate. But you take someone who's a 6-cup-a-day coffee drinker, the effects on heart rate and blood pressure are much lessened in the chronic exposure to it than they are in acute. Someone who never drinks coffee has a double shot espresso and then regrets it like an hour later because they got this pounding in their chest. There's some people that are sensitive, but by and large, I can't tell you that coffee has caused the complications of hypertension, heart failure, and all the other things. But we do recommend a half hour at least elapsing between previous coffee intake and blood pressure measurement, simply because we want to know the resting blood pressure in an individual in terms of prorating their cardiovascular risk. That's the reason it's prescribed by our technique protocol.
What if they drink coffee every day, all day, though? Would testing them in the context of not having drunk coffee not be reflective of the blood pressure they're actually subjected to?
Touche. I'll just leave it at that. Touche.
Okay. I have to ask you this question as a nephrologist. There's ongoing debate around protein and kidney function.
Yep.
Also blood pressure. Debate around the optimal total protein intake, but also protein source, animal versus plant, and how these things could affect long-term kidney health or blood pressure. What are your views based on the literature today, and has that evolved or changed over the years?
So I'm probably going to incur the wrath of several of my more pure kidney colleagues. I'm a kidney doc who does blood pressure care. I don't do much in terms of chronic kidney disease or worse yet, dialysis management, because those require very specialized lifestyle of the kidney doctor. And the ability to walk through a dialysis unit and not put yourself on Prozac afterwards is quite challenging. Those folks have just amazing lives, but a lot of sadness in a dialysis unit. That said, 1 gram of protein per kilogram body weight is often the metric that people use to say what's a good protein intake for a person. Animal proteins are said to be worse for you than plant protein, but we used to prorate your protein intake by virtue of how similar that protein, whatever it is, steak or whatever, how similar it is to an egg white. So the albumin in an egg white is the ideal protein. And when you look at your bloodstream, half of your bloodstream's protein is albumin. So if you're going to eat a diet with protein, it makes sense to have it similar to the amino acid content of albumin. And that said, that's one way to approach the ideal. But the kidney's pretty smart. And when you eat more protein than you need, you excrete it. You can't store protein. You can store fat. You can store sugar, but you can't store protein. Protein is either use it or lose it. So the kidney is your lose it mechanism for getting rid of it. If you eat more protein consistently than you need, you generate urea nitrogen, blood urea nitrogen. That's a waste product from protein metabolism, and you excrete it. The other thing that comes with protein, because protein is amino acids, is acid. And the kidney is also your source for excreting acid. And we tend to have an acid diet by and large. based in part because of the amount of protein that we eat. But the kidney's pretty good at keeping the pH, the overall balance of acid and base in the body, in check, because it has other mechanisms that it can use to balance the ability to excrete acid, coupled with the ability to generate bicarbonate or base to balance the acid effects of our diet. In general, the less animal intake of protein, probably the better. I think that people that call for that are probably reasonably secure in the data that says that. What's lacking here, and we had a renal fellow, kidney doc in training years ago that was really interested in what happens to your protein when you cook it. We talk about, what a steak is like in terms of the amino acid content, but that's before you cook it. When you cook it, stuff happens. Crazy stuff happens. And I listened to that 1-hour talk he gave, and I haven't heard anybody else do it since. But it was fascinating, the changes that occur in protein when you cook it. Broil it, bake it, boil it, whatever it is. Stuff happens, the chemical bonds and other stuff in there. So I consider myself a neophyte when it comes to the best protein intake, etc. to have. I just think that there's no reason to down kilograms of protein in the course of a day. Your body needs about 1 gram per kilogram body weight. So average person, that's 80 to 90 grams of protein a day.
There is some school of thought, mostly from exercise literature, looking at really maximizing hypertrophy or muscle growth. So how relevant this is to the everyday person is questionable, but that literature is often cited, and the protein intake level that's considered optimal there is about 1.6 grams per kilogram, so higher than what you're talking about. And I know people will be interested that have come across that and perhaps are interested in building muscle and are consuming 1.6 grams per kilogram. Do you think at that level, is it deleterious in any way to kidney function? Because I know people come across information where it's like, no, that high intake level actually could be damaging your kidneys, and then they're a bit worried about that, of course.
So my first knee jerk here is to say, I just don't know, because I just don't know, truly. But I'll tell you what I think. And the issue is that what happens to the kidney in terms of things like blood flow, and especially the blood flow through the filter units. Each of your kidneys has about 1 million filter units in it. They're called glomeruli. And the blood flow through the glomeruli is very tightly regulated by a balance in the front end, input into the glomeruli, blood flowing in, and the back end, blood flowing out of the glomerulus. When you eat protein, you dilate that afferent, that leading in blood vessel. That exposes your filter units to a little bit more of the blood pressure down upstream from them. And consequently, that hyperfiltration has no deleterious effect in the short term that we know of. But over time, the glomeruli change as a result of the repeated exposure to hyperfiltration. And they generate a thing called mesangial hypertrophy. So within the glomeruli are these support cells that keep all the tangle of blood vessels in there where the filtration occurs of the blood to make urine. That tangle in there is held together by a glue type cell called the mesangium. And when you repeatedly have hyperfiltration, greater amounts of blood flowing, greater amount of filtrate made, the mesangium often expand a little bit to handle that. Typical patient that has that is a patient with diabetes, where diabetes has affected their blood, the glomerulus, the blood flow in the glomerulus, and that emulates the same damage we see with hyperfiltration. Over years, the hyperfiltration may wear out the kidney's reserve and then begin to take its toll on kidney function. But honestly, Simon, that takes 10 to 20 years, I think, before that happens. You won't see it in a short-term 3 to 5 year study that typically we fund for these kind of things. But that would be my worry about a 1.6 or higher gram per kilogram body weight protein intake over time, is that you burn out your kidney's reserve, and then you're going to begin to chip away a little bit more quickly at the natural loss of kidney function over time due to the hyperfiltration that several of the key amino acids in protein cause a part of the kidney.
Is there anything here? This has been another masterclass. I really appreciate how clear you communicate the science, how respectful you are to the listener and your patients, and how objective you are. And I very much appreciate, just before you said, the honest answer is I don't know. And I think that's a response that deserves to be repopularized, and we should hear that more often from people in science. So thank you for reminding us of that. Is there anything related to lifestyle changes or lowering blood pressure that we didn't cover today, or that you wanted to add on to here at the end?
Yeah, just one quick plug for the weight loss component to blood pressure. You don't have to lose 40 to 50 pounds. I may have misled if you assume that, I got to lose 40 pounds to see a blood pressure response. Actually, you get a blood pressure response on the first 10 to 15 pounds. So you see it, and actually you get more blood pressure response up front and less over time as you lose weight. So the rewards from weight loss are actually achievable within a couple month time period. So you don't have to labor for 2 years to get 40 pounds gone and finally see something happen to your blood pressure. It's a more short-term effect than that. And I think it's one of the incentives to weight loss is the fact that changes do occur pretty quickly when people make the changes in dietary calorie intake and exercise to see blood pressure improve.
And just to be clear, that improvement in blood pressure is reliant on sustaining that weight loss over time. If the person is to put the weight back on, you would assume that blood pressure would come back.
They do lose it. Yep. Yeah, and the effects of exercise on blood pressure, if there are salutary effects in an individual, if you go 6 weeks or longer without exercising, it tends to fade away after that. It's not a very long, sustained benefit. It's sort of like you need to keep at it.
Have you come across any of the literature looking at sauna and blood pressure?
No, I got asked that a long time ago, and I always meant to look that up. But I have not. There are some countries where a lot of business is conducted, I think in the Scandinavian countries in particular, in saunas. And there was I belong to this group called North American Artery, and there was a couple of presentations a couple of years ago on the effect of, heat in a steamy type circumstance on blood vessel function that looked salutary. So I wouldn't be surprised if it helps, but I don't know how much.
Well, that's your homework. Come back to me on that.
All right, great. Absolutely. I'll be an expert.
I want to leave the audience with something different today. My question to you is, if you could go back and give your 20-year-old self a piece of life or career advice before beginning this 40-plus year journey that you've had in medicine and science, what would it be?
Good question. And the answer is that don't adopt a skeptical attitude until you've really thought it through. Two aspects to that, and I'll quickly do this. When I was a resident, and this is when I was in my late 20s, I was on a kidney service seeing a patient in the ICU. And I came in and I did my consult, waiting for my attending to come and bless my consult. And I wrote up all these things. And the resident, my colleague, same year as me, but running the ICU side, not my kidney side, came in and said, "This is what the kidney people always do. They take over our patient care." And I was incensed. And then my attending told me, Ray, every once in a while, when someone says something like that to you, the first thing you have to do is not get mad at them, but ask, and he was Irish, is there a bit of truth in what they're saying? And so I looked at it and I thought, oh my God, there is. He's right. I just don't like what he said. So the idea of immediately reacting to what patients do or say, that took me a while to get over, but I think eventually, once you become a better listener and less prone to react quickly to what people say or do, I think that's valuable life advice that I would give my 20-year-old self in a heartbeat.
Amen. Thank you for sharing that. And thank you for coming back and being with us again. Appreciate it.
All right. It's a pleasure, Simon. Best.
There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to to take control of your health. I look forward to hanging out with you again in the next episode.